Next is the last presentation of the session. We have Dr. Vineetha Vijayan. She's presenting on morphometric analysis of subretinal hyperreflective material in age-related macular degeneration.
Good afternoon. My topic will be on morphometric analysis of subretinal hyperreflective material in ARMD. So coming on to the introduction, SHRM, as you know, is one of the new few biomarkers in AMD, and this SDOCT feature is identified as a hyperreflective material located between the neurosensory retina and the retinal pigment epithelium. It may consist of fluid, fibrin, blood, scar, or fibrovascular tissue, and this composition may change with time with anti-VEGF therapy. So it is important to characterize the SHRM so as to prognosticate the disease and to limit the number of invasive and costly interventions. So coming on to the aim, it is to evaluate the association of morphological features of SHRM with visual acuity in eyes with NAMD and compare it with those patients with, of NAMD without SHRM. It's a retrospective study conducted for a period of 1 year. 100 wet AMD eyes with SHRM was included, 50 eyes without SHRM was included, and all of these were treated with anti-VEGF therapy. The inclusion criteria were patients diagnosed as NAMD with SHRM captured on OCT at baseline visits, patients diagnosed as NAMD without SHRM captured on the OCT at baseline visits, treatment naive status at baseline, 1 year follow-up with BCVA and OCT imaging. The exclusion criteria being poor visibility of SHRM, prior treatment, and other ocular conditions. So the image analysis was done. The initial diagnosis of NAMD was made using the Spectralis Heidelberg OCT FFA imaging, and the scan pattern was done, included the macular dense scans, and pure quality images were that obscure the SHRM morphology was excluded from the study, and a subgroup analysis of the SHRM was taken, and based on the location of the SHRM at the fovea outside the central 1 millimeter subfield, the dimensions that were included were the height, width, area was measured at baseline, and the changes of were recorded at 3 months, 6 months, and 12 months post the anti-VEGF therapy. Coming on to the results, the male to female ratio was 1:1.9, and the mean age was 72.5. The mean BCVA at baseline was 0.68 in eyes with SHRM and 0.46 in eyes without SHRM. At 6 and 12 months, the BCVA did not differ significantly between the patients with SHRM and without SHRM. The mean BCVA at 6 months was 0.5 for eyes with SHRM and 0.35 for eyes without SHRM. The mean BCVA at 12 months was 0.52 logmar for eyes with SHRM and 0.45 logmar for patients without SHRM. So coming on to the location of the SHRM with visual acuity, the presence of SHRM was associated with worse visual acuity at all locations regardless of the height or width when compared to the control groups, and the foveal involvement of SHRM had the worst visual acuity at all groups, the baseline 3 months, 6 months, 12 months when compared to eyes with absence of SHRM in the central 1 millimeter square of the fovea. The SHRM morphology and with visual acuity showed that the hyperreflective SHRM at baseline was found to have the worst baseline and final visual acuity. Well-defined SHRM was associated with poor baseline visual acuity, and presence of IRF was also associated with poor BCVA. A subgroup analysis was done, and based on this, we divided the patients of SHRM based on the height greater than 500 micrometers and less than 500 micrometers. And improvement in vision was seen in both groups from baseline to 12 months post injection, which was however not statistically significant. The SHRM width again was divided into subgroups, that's greater than 1500 micrometers and less than 1500 meters, and from baseline to 12 months post injection there was improvement in both groups and it was statistically significant. The area again we divided into 0.15 and greater than 0.15 and less than 0.15, and improvement was seen in vision in both groups, and that was statistically significant. Coming on to the discussion, In the CAT analysis, 77% of the eyes showed SHRM at the time of enrollment, with the decrease to 54% after 2 years of treatment. So this current study showed the presence of SHRM in 75.84% treatment-naive eyes with NAMD and persistence of SHRM in 34.3% at the end of the year. Of the baseline OCT parameters, the presence of SHRM, the foveal involvement, larger baseline SHRM dimensions, increased reflectivity, well-defined SHRM borders, SHRM associated with IRF, EZ loss were all associated with worse visual acuity at 1 year after treatment. SHRM a width of greater than 1500 micrometers had the worse visual acuity to a greater extent than the height and area. So the loading dose of anti-VEGF therapy correlated significantly with the decreased SHRM dimensions, and height declined slowly after that. Anti-VEGF therapy decreased, what we postulated is that anti-VEGF therapy decreased the capillary endothelial permeability, thereby reducing the vascular fluid leakage, and this rapid decrease in SHRM thickness would cause the reduction in the fluid component of SHRM induced by anti-VEGF therapy regardless of the drug and regimen. The SHRM anterior and posterior borders were defined, correlated with worst baseline visual acuity and follow-up visual acuity. So coming on to the other studies, Kumar et al. Could not find a significant correlation with the visual acuity and border definitions. Pocrio et al. And Casino collaborated with CAT's analysis, and they also did not find any significant difference. In our study, there was a well-defined SHRM borders were associated with poor visual acuity, and Shafareddin et al. Reported the reduction of thickness and volume accompanied an increase in the mean reflectivity following the anti-VEGF therapy. In our study also, the hyperreflectivity was associated with poor visual acuity and was a topographic biomarker for retinal fibrotic scar evolution. So in a nutshell, the positive biomarkers of good visual acuity after the anti-VEGF therapy was hyperreflectivity of SHRM, ill-defined borders, thin SHRM, disappearance of SHRM. Negative were the foveal involvement, hyperreflectivity of SHRM, well-defined SHRM, thick SHRM, greater height, width and area. So SHRM is a surrogate OCT biomarker. Incidence of fibrotic scar formation was higher with hyperreflectivity, and incidence of geographic atrophy was independent of the presence or absence of SHRM. It's a retrospective study, and absence of correlation of multimodal imaging was one of our limitations. Thank you, sir. Yes, sir. Yes. So the negative biomarkers I had mentioned was the foveal involvement of SHRM, then the hyperreflectivity of SHRM, and well-defined SHRM borders, and the increased area, the width and height of SHRM would all result. It would prognosticate that.
No, what are your recommendation for these negative biomarkers? How one should
we have to
treat
probably
them?
intervene more. We have to
So intervene
reduce,
more in the sense.
probably switch the anti-VEGF regimen, or we have to increase the frequency of anti-VEGF therapy.
Thank you.